Good morning, everyone. Well, it's 8:01, so I think we can go ahead and get started. Welcome to this week's WashU Internal Medicine Grand Rounds. This week, we'll be concluding our Chief Medicine Grand Rounds for the year with two really great talks by Drs. Hima Atluri and Dr. Alyssa Self. Since we'll have two talks today, we'll save all of the questions for the end, but if you have any questions for either of the speakers during the talks, feel free to put them in the chat, and I'll read the questions out loud to them after our second talk. So we're going to start off today with Dr. Hima Atluri. Dr. Atluri grew up here in St. Louis, Missouri, after completing and came back to St. Louis after she completed her 6-year BA/MD program at the University of Missouri, Kansas City, where she graduated summa cum laude with honors. She found herself back here in St. Louis to finish her internal medicine residency and chief residency here at WashU. And we'll miss her next year when she moves to Houston, Texas to start her Heme Onc fellowship at MD Anderson. Today, she's going to be presenting her grand rounds on an incredibly relevant topic for us all on India's COVID-19 crisis. Thanks so much, Dr. Atluri.
Thank you, Dr. Geisman, for that introduction. Like she mentioned, my name is Hima Atluri, and I'm one of the current chief medical residents here at WashU. Over the last 2 months, as vaccination rates here in the US and restrictions have been lifted for the COVID-19 pandemic, this is a very different story that is playing out in India. And so as we've seen on the media outlets, a lot of lack of oxygen, overcrowding of hospitals, and kind of questions as to how we got here, I wanted to look into that a little bit further. So to start, I have no financial disclosures. So my objectives for this talk are, one, to discuss India's first wave, which was able to overall successfully kind of flatten the curve and not overwhelm the system as much as initially was expected. Identify key events leading to India's second wave, discuss the B.1.617 variant and vaccinations in India, and then discuss ways that we can provide aid to those in India. So I kind of took this initial chart from the New York Times, and then I went ahead and plugged in kind of the key events that I think were instrumental to the first wave, and then the key events that I think have contributed to the now devastating second wave in India. So this first part of the talk, I will focus here on the first wave of India, the pandemic in India. So the first case of coronavirus in India was actually reported on January 30th, 2020, when a student had come back from Wuhan, China to India. And then kind of over February and into March, there was a slow rise in cases. So there was several tourists that had tested positive for COVID. And right when the case count was around 500, Prime Minister Narendra Modi had declared a nationwide lockdown on March 24th, 2020. His initial plans for this lockdown were a 21-day lockdown. And this is actually considered one of the strictest lockdowns in the pandemic worldwide. So all transport services, including road, air travel, railroad travel, were suspended, and only essential services such as food shops, banks, gas stations, and hospitals were allowed to be open. If an individual was found to be outside their home during this lockdown and they weren't an essential worker, they were at risk of getting arrested. And so there were actually multiple arrests that were made during this lockdown period if they were seen to be outside their home. There were several religious gatherings that happened during this period, during which multiple arrests were made. And so the lockdown had actually kept getting extended until about the end of May, at which point there was kind of an eased unlocking period where if caseloads were meeting a certain criteria, we could ease restrictions. So overall of this nationwide lockdown, as we could see here in this wave, actually helped mitigate a lot of cases. And then kind of after the unlocking period began is when the caseload started to increase. So he received a lot of praise for this lockdown, but in addition received a lot of criticism for it. So when this lockdown was announced, there wasn't a lot of time that was really allotted for individuals to go back to their hometowns. So lots of migrant workers work in the really densely populated cities in India, such as Delhi and Mumbai. And so when the lockdown was implemented, they were forced to return home to their small town villages. So the issues with that are that, in these bigger cities are kind of where you're at risk for getting exposed to the coronavirus. And now you're moving thousands, hundreds of thousands of people back to their villages. And so potentially carrying the virus to these smaller towns where there's less access to healthcare. There was a stimulus package that was released by the Indian government that was the equivalent about $24 billion. However, while it did reach many individuals, many workers did not receive any relief from the government. And an issue that, I think we've all seen in the beginning of this pandemic is that there were low testing rates, and relative to India's population, they were kind of on the lower side of that. And so there was concern that there was a lot of underreporting during this first wave of the pandemic. And in addition, due to already difficult access to healthcare, on top of it, with the lockdown on top of that, there was also treatment delays for other conditions that are already very prevalent in India, such as TB, that were now getting delayed treatment. And so during this kind of migration, there was several deaths that happened due to starvation, road accidents, etc. And then one picture that I know that definitely made its rounds on the media is this one on the bottom where several workers are getting sprayed with disinfectant on their way back to their villages as a way to kind of mitigate any potential virus that they could be carrying. So overall, relatively, India was able to flatten the curve and was actually surprising to several people. And so a lot of alternate theories kind of popped up for what could have led to this success. So one thing that kept getting mentioned over and over again was that the mortality rate for COVID was very low in India, as some cited as low as 1.5%, and that there were a lot of symptomatic or mildly asymptomatic cases. There were some articles that came out saying that, is there cross immunity from exposure to other human coronaviruses that's causing some, conferring some protection for the novel coronavirus through some cross immune reactions with T cells. And then some small studies claimed that there is a high seroprevalence and that herd immunity was imminent. So this is an article that was released by the Municipal Corporation of Greater Mumbai, where they tested about 6,000 individuals in slums of Mumbai, and they quoted a 57% seropositivity with antibodies against the SARS-CoV-2 virus in July of 2020 in the slums. And so a lot of, so people kind of thought like, oh, if there's already, we're at 57%, we're headed towards herd immunity and overall kind of sense of security. And so with that brings us to our second wave. So we can see here again, so our first wave peaked in the middle of September, and then we saw a slow decrease in the case count. And then in January, the vaccination program began. And then here at the end of March, we see a sharp increase in cases. And so there were a couple of key events and factors that I think played a role in this sharp rise in cases. So we'll discuss those now. So Prime Minister Modi's political party is the Bharatiya Janata Party, which I'll refer to as the BJP party from here forward. At the end of February, when case counts, as you can see here, are very, very low, released a statement kind of highlighting all of the successes that the party had done for the pandemic over the last year. So they talked about the nationwide lockdown, the stimulus package, talked about how India is a leader for vaccine production and exportation. And within this statement, one paragraph that really caught my eye in one sentence was, the party unequivocally hails its leadership for introducing India to the world as a proud and victorious nation in the fight against COVID. So the government was really kind of saying that COVID was really managed and that India has emerged victoriously. And so a lot of restrictions that were placed on large gatherings were lifted, and people started to feel comfortable going out unmasked, attending larger gatherings such as weddings, political rallies, and so overall had a sense of safety. And also kind of in the following month in March, Prime Minister Modi had some political interest in West Bengal, which was holding its assembly elections. So West Bengal is the fourth most populous state in India. And they were holding their elections that were starting at the end of March, going through April, with the elections planning for May 2nd. And so the BJP party has never won power in the state. And as with most political parties, they want power in whatever states that they can get. And so there were multiple rallies that were held at the end of March and the beginning of April, where there were thousands of individuals that had come to support the political rallies. And then as Prime Minister Modi had his rallies, some of the competing political parties also held rallies of thousands of people, and you can see a lot of whom were unmasked. And so kind of at the beginning of April, when the caseload was starting to tick up, he received a lot of backlash for these rallies and actually had canceled several that he had planned for later in April. Also during this time period, kind of January through April, there was a large Hindu ceremony called the Kumbha mela, which was planned for, the majority of which was planned in April. So the Kumbha Mela is a Hindu religious ceremony and occurs approximately every 12 years. And it's considered one of the largest peaceful gatherings in the world. So this Kumbha Mela typically occurs at 4 riverbank pilgrimage sites. And the one in April was done at the site called Haridwar on the banks of the Ganges River. And the main symbolic event here is that you would bathe in the Ganges River as a way to atone for your sins. And so there was a lot of restrictions that were in place kind of January through March on the Kumbha Mela. And so not many individuals were going to do this. But in April, this was sanctioned more by members of the BJP party and the government of India, saying that, there will be COVID testing in place. They encouraged masking, but said that you can attend this religious event. So in the month of April, about over 6 million people went to the Kumbha Mela celebration and is now considered super spreader event. So this is a picture from the Kumbha Mela this year, and you can see how close everyone is unmasked. There's a few people masked back here. And then watching news reports on this, while COVID testing was supposedly required prior to this, it actually was not enforced. So again, looking to some propaganda here. Propaganda is not the word, but some advertising for the Maha Kumbha Mela. And here it says there's a 1,500 bed COVID hospital that's nearby. They encouraged masking, but did sanction individuals going to this event. And then here's another picture from the Kumbha Mela this year with just thousands of individuals there. So one thing that's been rampant throughout this pandemic is misinformation. So WhatsApp is a very popular form of communication in India. I know that my parents sometimes text me through WhatsApp, and a lot of family members and friends in India will message me through WhatsApp. And a lot of times it'll be these forwarded images, forwarded stories, forwarded information, often fraught with a lot of misinformation. And just to give you a sample, these are messages that I have personally received on WhatsApp that have been circulating in India. So this one, stop eating bakery items. It's strictly advised to not eat bakery items as it's not washable and can get infected to the virus easily. This one says that coronavirus hangs out in the throat for several days and that gargling salt water and vinegar can help stop the spread. People blessed by Hindu gods won't get coronavirus. And then this is another message that I got talking about how vitamin D can confer a level of immunity against the coronavirus. And so just to touch again on the people being blessed by Hindu gods won't get coronavirus, that was another message that was sent by the government saying that, this is for the Kumbha Mela, this is a religious ceremony. So God will give you some level of protection, or like the Ganges will wipe corona away, are some headlines that I had seen. The other big major factor that I want to talk about leading to the rise of the pandemic and the second wave is the B.1.617 variant, also classified as the Delta variant or the double mutant. It was first described in India in October of 2020 and is considered the predominant strain. And so the WHO has labeled it as a variant of concern, meaning that there's a chance that it could be more transmissible. So at this point, we think vaccines are thought to be effective against this strain, but we don't have actual concrete data on it, and we don't have actual data on if mortality is higher. There are some animal studies that show that in mice infected with this variant, there was increased lung inflammation. And so, maybe that is something that we'll kind of get more information on as it comes. And then the term double mutant is actually a misnomer. It actually comes from the fact that it shares two similar mutants to variants that were first identified in California or South Africa, but it actually has about a dozen other mutations. And so that's why they think it's more easily transmissible and can evade the immune system. So talking about kind of fatality and the mortality of India, because there was a lot of information saying that is the mortality rate lower in India. I think it's hard to say. I think right now what we do know is that there is a lot of underreporting of cases in India. And so the New York Times actually released this chart, which I liked, saying these are the official counts of cases in India. So 26.9 million official reported cases, 307,231 deaths as of May 24th. And then saying like a conservative scenario would say about 600,000 estimated deaths, and a more likely scenario saying 1.6 million estimated deaths, and that's assuming a fatality rate of 0.3%. So I think, there is a huge amount of underreporting here because one, there's a lack of access to healthcare. With the hospitals being overrun, many people are being sent away and unable to get tested. Although compared to the first wave of this pandemic, those rates are significantly higher. And so, but also our actual infectivity rate is higher too. So it'll be, I don't know if we'll ever know the official numbers here, but I do think that there is a large population of people that we're missing that are actually infected and are likely dying from COVID. Which brings us to what are some of the strategies now on how India is fighting this pandemic. So India is the leading producer of vaccines. And so many countries were actually dependent on India for their vaccines. And so India had promised about 5.5 million doses of vaccines to different countries. And Prime Minister Modi had suspended exports of those vaccines as the numbers in India had started to increase. So, why looking at this curve on vaccinations, you can see at the beginning of January and as vaccines were rolled out, it was a very slow uptick. And as India started to see a rise in COVID-19 numbers, so did the number of people getting vaccinated. And so part of that, again, I think is with related to the misinformation. Some people were like, if I'm not going to get symptoms from it, why would I get vaccinated? Or, if there's herd immunity, why would I get vaccinated? Type of thing. But now seeing that people are getting infected and people are dying from this, the vaccinations have been increased, in addition to branding from the government and encouragement for everyone to get vaccinated, even if they've been infected before. So as of right now, India is vaccinating about 3 million people per day, and the vaccine is available to anyone over the age of 18. So there are three main vaccines that are being administered in India: the Covishield vaccine, which is the Oxford AstraZeneca product, Covaxin, which is a Bharat Biotech product, and then Sputnik 5, which is a Russian product and just approved, I think it was on May 14th. So Covishield is a 2-shot vaccine, and it's about 90% effective after the second shot. Covaxin, 81% effective after the second shot. And then Sputnik 5, about 92% effective after the second shot. So interestingly, Sputnik 5, just kind of as a side note, uses 2 different adenovirus vectors and slightly different strains in each shot. So your first shot and your second shot are different, which is not a strategy that I had seen otherwise. And so the big question is this vaccine protecting against the variant? We don't have a lot of information on it just yet. So there was a preprint out of Emory University in Stanford that showed that convalescent individuals vaccinated with Moderna or Pfizer is effective in neutralizing this variant, although less potent than some of the other variants that we've seen. And we don't really have data yet on the effects of Covishield. There was an article in Nature that kind of alluded, saying that a lab in Hyderabad had gotten similar results to that, but we just don't have concrete data on that yet. So what is India doing now that we're starting to see a decline in cases? So there was not another nationwide lockdown that was implemented, but state by state, there were several restrictions and curfews that were in place with a limit in mass gatherings. And now we're also starting to see a decline in cases overall, likely with these mitigation efforts and as vaccination rates are starting to increase. There's also a lot of international aid that has gone to India to provide raw materials for vaccines, PPE, and oxygen supplies. Overall, it seems like some of these mitigation factors are working. However, India still has a long way to go. Only about 3% of the population is currently fully vaccinated against COVID. And they're anticipating maybe until the end of the year, until we see higher, more like 70% rates. So it'll be kind of interesting to see how that plays out. So watching all of the media outlet and talking to family members and friends in India, I felt kind of helpless over here. So I wanted to know, how can we help? So one, fight misinformation, provide accurate resources to those living in India. So, if you get those WhatsApp messages kind of explaining, hey, this isn't accurate, this is what we know, this is what we don't know, encourage vaccination. And if you don't have family members or know anyone in India, I know I still felt pretty helpless. And so there was different organizations that you can donate to. And I'm happy to provide these links via email for SIVA International, UNICEF, or the AAPI, which are providing PPE and oxygen supplies to India. So overall, it seems like, there were a lot of different events that led to the new spike in cases in India, related to largely a lot of misinformation and a false sense of security. And so I'm really happy to see that the cases are declining, but I do think that we're a long way away from recovering from this. So with that, I want to say thank you to Dr. Frazier and Dr. Costco for all of their mentorship this year, and for the opportunity to present at Grand Rounds today. My co-chiefs, the House staff for a wonderful year, Dr. Mithali Thanawala, who's a friend of mine from med school and helped me review this presentation. And then of course, my mom and dad, who without their sacrifices, I would have nothing that I have today. These are my references, and then we'll save questions for the end, but thank you all for listening.
Thank you so much, Dr. Atluri. That was a really great talk. Very insightful, a lot of good knowledge about the India COVID crisis that I didn't know before. So next up, we'll have Dr. Alyssa Self. Dr. Self graduated with honors from Brown University with a bachelor's in biology. She then went to the University of Colorado School of Medicine before finding her way to Washington University for her internal medicine residency and chief residency. We will also miss her next year when she moves to San Diego to start her pulmonary and critical care fellowship at UCSD. Thanks so much, Dr. Self.
All right, thank you, Taylor, for the kind introduction. So like she said, I'm Alyssa Self. I'm one of the current internal medicine chief residents, and today I'm going to be talking about subspecialization in internal medicine, a historical perspective. So I have no financial disclosures. So the objectives today are to describe the history of specialization and subspecialization in medicine, describe the factors that drive physician specialization, and review some of the benefits and pitfalls of subspecialization. So I want to start by discussing the educational reform that was a major driving force behind physician specialization. In order to do that, let's first take a look at the state of the US medical school system at the turn of the 20th century. So at the time, the majority of physicians earned their diploma from these proprietary medical schools, which were one-year programs and essentially diploma mills. A minority earned their degree from four-year university-based medical schools, one of which was Johns Hopkins, which was founded in 1893. And very few people completed any postgraduate education in the form of an internship. So pictured on the right, at the top is William Henry Helch, who was the first dean of the Johns Hopkins Medical School, and who had a major role in creating the four-year model. Below him is William Osler, the father of medicine, who played an instrumental role in the creation of postgraduate clinical training. So in the early 20th century, the Carnegie Foundation identified that improvement in the American healthcare system was one of its primary philanthropic concerns. In order to achieve this goal, the foundation deduced that they really needed to improve the suboptimal state of the American medical education system. So in came Abraham Flexner, who was an educator, but not a physician, and had never set foot in a medical school before. So he was tasked with surveying all of the medical schools in both the United States and Canada, and then providing suggestions for their improvement from the perspective of an educator. So in the Flexner Report of 1910, he determined that about only a third of the medical schools in existence at the time provided adequate training. A third were, okay, and then essentially a third were of such poor quality that they should be closed immediately. As a consequence, there was a shift towards the four-year model, or the Hopkins model, which consisted of 2 years of preclinical work and then 2 years of clinical experience. These four-year medical schools began to replace the proprietary schools, and over the next decade or so, there was a significant decrease in the overall number of medical schools in the United States. So by 1914, significantly more physicians, about 75 to 80%, were obtaining postgraduate training in the form of completing an internship. And by the 1920s, the majority of US physicians had completed 4 years of medical school, as well as a one-year internship, and the vast majority were practicing as general practitioners. So while the Flexner Report and US medical education reform did not directly lead to specialization, the marked growth in scientific investigation and medical knowledge that resulted from this more rigorous and research-based education was a major drive towards subspecialization. As medical scientists began to specialize, they devoted their intellectual energies to understanding more and more about narrower topic areas. These general practitioners began to differentiate into physicians with specific areas of expertise, and often devoted some or all of their work to that specific area. As physicians began to focus their areas of clinical practice and scientific investigation, the need for board certification or certification of professional standards became increasingly important. So the first specialty board that was formed was actually ophthalmology in 1917, which was largely in response to the growing field of optometry, since it was a way for the specialty to differentiate itself and say that ophthalmologists had met a certain set of standards and qualifications. Other specialties soon followed suit, and four formed the Advisory Board of Medical Specialties, which was later renamed the American Board of Medical Specialties in 1970, which is what it's currently named. The American Board of Internal Medicine soon followed suit and was created in 1936 as a concerted effort between the American Medical Association and the American College of Physicians. So at the time of its creation, the ABIM said that consideration would be given to the more limited specialties of internal medicine, such as cardiology, gastroenterology, allergy, tuberculosis, which was later renamed to pulmonology, et cetera. And so in 1940, it established a policy where candidates who wish to become certified in these areas would have to pass an oral board examination that was administered by a specialist in the area of focus, and then their certificate would denote a certain degree of proficiency. So in the following decades, there was a trend towards subspecialization. So World War II actually led to pretty profound changes in both medical education and medical practice. During the war, the military recognized physicians with specialty expertise, either with or without board certification. And then these specialists were given higher rank and assigned to specialty assignments, which were sometimes more favorable. So after the war, there was a major shift from general practitioners to specialists, including internal medicine. As you can see in the figure on the left, there was a significant increase in the percentage of internal medicine physicians who chose to subspecialize. As you can see on the left, between 1951 and 1960, only about 7% of internal medicine residency graduates were choosing to subspecialize, whereas by 2011 to 2015, 88% of subspecialists chose to of internal medicine graduates chose to subspecialize. And you can see it also kind of the percentage of physicians who chose to subspecialize also markedly increased after the 1970s, a trend that's continued. So here's the timeline of the internal medicine subspecialty creation, with the increase in available subspecialties occurring in parallel to the increase of the percentage of internists subspecializing. Some of these are built on further specialization of large subspecialties such as cardiology and gastroenterology, whereas others such as sleep medicine, sports medicine, geriatric medicine span multiple disciplines and allow different pathways to certification. So in 1970, the ABIM initiated several major changes in response to this trend towards subspecialization, which included the creation of new specialty boards and the requirement for 2 additional years of formal training in the said field in order to actually qualify for board certification. Before that, sometimes you could do 1 year and it could be incorporated into the residency itself. And so while these changes were pretty controversial at the time, they've actually remained relatively intact and just expanded upon since. So as in earlier times, the progress of biomedical science continues to be a major factor in the emergence of new subspecialties. So 2 examples I want to highlight are advanced heart failure and transplant hepatology, which are tertiary specialties that really arose from the growing need for extended medical care of complex patients before and after heart and liver transplantation, respectively. So creation of these subspecialties recognizes that there are specific patient populations who would benefit from the highly focused knowledge and skills obtained through training and certification beyond that of a general cardiologist or gastroenterologist. So these tertiary subspecialties also require high patient volume to maintain proficiency in their skills. And this is the case at our institution. They're usually based at large academic referral centers. So what is the current state of things? So today the ABMS consists of 24 member boards and certifies within the entire field of medicine, including surgical subspecialties or specialties, 40 different specialties, 87 different subspecialties. And within internal medicine, you can certify in internal medicine, and then 22 different certifications within that, 5 of which are tertiary subspecialties such as advanced heart failure or liver transplantation, as we just discussed. So why have physicians chosen to become board certified? So the demand for board certification is partially physician driven. There was this 2006 survey completed by Lipner and colleagues that actually found that professional image was one of the primary reasons that physicians thought that board certification was important. All the proposals for new subspecialties have initially come from specialty societies, often with the support of different patient groups. And given the ever-growing demands for greater transparency and higher standards of care, board certification is a way to demonstrate to patients that physicians have a certain level of knowledge and skills necessary to provide high-quality patient care, as is shown highlighted in this figure from the ABIM website. So how do you go about creating a new subspecialty? The criteria used in considering a request for a new subspecialty status in internal medicine are outlined in the New and Emerging Disciplines in Internal Medicine 2 report, which was last published in 2006, which is the second version. So it must represent a unique body of knowledge that cannot be incorporated into the parent discipline. It must have clinical applicability. It must be based on and contribute to the research base of medicine. It must offer evidence that the discipline improves patient care, has to require supervision and direct observation in a formal training setting, involve complex technology or specific skills. And finally, the positive value for certification must be greater than the negative impact on general internal medicine or an existing specialty. So there have actually been specialty applications such as clinical pharmacology and obesity medicine that have not been approved to date because they did not meet one of the standards that I discussed, or were deemed to be insufficiently mature. And an application for a vascular medicine fellowship is currently pending review on the ABMS website. So there's clear evidence of specific competence. The clear evidence of specific competencies is a central component of the consumer demand for transparency. And so physician specialists themselves are requesting to be certified in more narrow areas of expertise that better reflects their clinical practice. So I want to discuss two different alternate pathways outside of the ABMS certifications that physicians can further subspecialize and gain knowledge. So one example of this is the Focused Practice in Hospital Medicine Maintenance of Certification Program. It was initially piloted by the American Board of Internal Medicine and American Board of Family Medicine in 2010, and then approved by the ABMS as the first focused practice designation in 2017. So this program assesses, recognizes, and sets standards for the specific knowledge, skills, and attitudes of general internists who focus their practice in the care of patients in an inpatient setting. And as you can see in the figure on the right, it shows the breakdown of the examination, the certification exam, that the typical ABIM exam versus that of the hospital medicine exam. You can see how the content differs and is specifically tailored to hospital medicine practice. So while this program is not a subspecialty itself, it is a variation of an internal medicine certification that, upon completion of the program, identifies physicians as ABIM board certified in internal medicine with a focused practice in hospital medicine. So other routes of obtaining further subspecialty knowledge and training are through many of the many non-ACGME fellowships, which provide medical education and training that occurs without ACGME recognition. Accreditation may or may not be available through a specialty board or the ABMS. And despite the variable availability of certification, completion of such fellowships allows trainees to obtain further procedural, clinical, and research training in developing areas of medicine that can then go on to further their career. So I've listed some of the many non-ACGME fellowships on the left, but of course it varies by institution and what is offered. And so one example I want to highlight of a non-ACGME fellowship is interventional pulmonology, which is a tertiary fellowship that upon completion of the 1-year procedural training allows for board certification through the interventional pulmonology board certification exam administered through the American Association for Bronchology and Interventional Pulmonology. So it still has a very set standards and provides a board certification at completion. So we've talked a lot about how specialists came to be, but do the specializing actually improve patient care? So it seems like a fairly intuitive topic, but let's take a look at the evidence and see. So the first study I want to discuss is one by Ansari and colleagues that found that cardiology care compared to management by a primary care provider in patients with newly diagnosed heart failure is associated with improved guideline adherence and a decreased risk of the composite outcome of death plus cardiovascular hospitalization. So shifting to a different field, Wilcox and colleagues conducted a systemic review and meta-analysis in 2013 to examine whether high intensity versus low intensity ICU staffing improved patient outcomes. So high intensity staffing was defined as a closed ICU or mandatory intensivist consult upon ICU admission, whereas low intensity staffing was no intensivist or optional intensivist consult. And so they found that high intensity ICU staffing was associated with significant reductions in both hospital and ICU mortality. And finally, again, shifting to a different field of medicine, a 2015 retrospective cohort study by Bay and colleagues of 6 academic and community centers found that mandatory infectious disease consultation for Staph aureus bacteremia resulted in reduced mortality, increased adherence to quality measures, such as appropriate choice of antibiotic and appropriate antibiotic duration. So these are just a couple of examples of how greater and more narrow expertise can be associated with improved clinical care. While there are definite benefits to physician subspecialization, there's been some discussion of whether the US healthcare system is becoming overly specialized. So what is overspecialization? So one definition that I found that had been proposed is that it is the redundant stratification of medical domains that could potentially result in worse clinical outcomes, less favorable patient experience, or higher healthcare expenditures. Some critics have raised concerns that overspecialization is one of the factors underlying US healthcare expenditures, which as we know, are one of the highest in the world. From 1940, when there was little specialization, to 1975, medical expenses increased from 3 billion to 75 billion. Of course, there are also many compounding factors there. So healthcare expenditure is now about 1/6 of our GDP. And there have been concerns that specialist fees, procedures, over-testing, and over-treatment have been contributing to these high health expenditures. Also, there's concern that given the number of specialists in the United States now outweighs that of primary care providers, perhaps that is contributing to our higher health expenditures as well. Other concerns that have been raised are about whether further subspecialization could cause further fragmentation of the US healthcare system, which could occur as specialists continue to focus on more narrow areas of study. This could result in lack of coordination of care given the number of different specialists that medically complex patients would be required to see, which could in turn also result in long wait times, over-testing, and over-treatment. So one of the main issues I want to touch on is that there's a projected shortage of primary care physicians in the US, which is something that has been in the news and something that we've heard about a lot over the past decade. So according to the AAMC, by 2033, there is an overall projected physician shortage, and the projected shortage of primary care physicians will be 22 to 55,000. There's also predicted to be a shortage of subspecialists or specialists at the time, but the figure is around 17,000. So the proportionate shortage of primary care physicians, the specialists, is significant. And again, just some further statistics about current trends in internal medicine resident subspecialty choices. So there's still a trend for internal medicine residents largely pursuing subspecialty career paths. And a survey of internal medicine residents that was completed by West and colleagues in 2012, published in JAMA, found that only 19.9% of categorical internal medicine residents plan to pursue a general internal medicine career plan, with more women than men expressing a preference for general internal medicine. And then within primary care tracks, this number increased to 39.6%. In another study, Howard and colleagues conducted a cross-sectional survey of medical students and found that of the nearly 1,200 respondents, 23.2% were planning careers in internal medicine, but only 2% of graduating medical students were planning a career in general internal medicine. So overall, in summary, I just want to say that specialization occurred as a result of expanding scientific and clinical knowledge. There's been a trend towards subspecialization in internal medicine, and while there are definite patient outcome benefits to subspecialization, there are also potential pitfalls. These are my references. Okay, and I want to say thank you to Dr. Fraser, Dr. Costco, the APDs, especially Dr. Jelsky, who I was paired with this year and who helped me a lot, especially at the beginning. All of my co-chiefs, Taylor, Abba, Hima, Natalie, Steve, and Ahmad, my partner, Dr. Evan Dupart, and the residents. And there's a picture of my cats, Rodrigo and Ives, so I'd like to thank them too.
Thank you so much for that talk, Dr. Self. That was really, really insightful. And I love the picture of Rodrigo and Ives at the end. So now we do have a few minutes for questions. So the first question is gonna go to Dr. Atluri. Dr. Atluri, one question that came through is there any information available on masking rates in India? And if so, is masking policy suppressed by the government as well?
Yeah, so that's a really good question. So there hasn't actually been a lot of information on what percentage of people are actually masking. I think one article I saw said that 90% of people were aware that they should be masking, but maybe about 44 to 50% of them were actually masking. But the government, unlike some stories that we've seen here, is actually promoting masking and wants to encourage individuals to do so. But there has to be like a lot of education on making sure that the mask is worn right, and then a lot of buy-in because it is very hot there. And so putting a mask on, it's uncomfortable. And so really kind of, and I think having everyone kind of see how much India has been suffering from this has encouraged the number of people that are masking, but actual concrete numbers I don't have.
Thank you so much. The next question will be for Dr. Self. Dr. Self, can a specialty-oriented internal medicine program train primary care physicians as well as specialists? And should primary care training be part of internal medicine programs, or should it be a separate entity?
Sure. So I think that a specialty-oriented internal medicine program is able to train both primary care physicians and specialists. I think with the current balance of rotations and required experiences within internal medicine residencies, residents are able to really gain experience in both and then choose their career path. I mean, we are required to do a third of outpatient time in our continuity clinic and gain a lot of primary care exposure that way, with the option to pursue more through various outpatient rotations if desired. Sorry, I'm just reading the second part of the question. And should primary training be part? And yes, I definitely think that primary care training should be a part of internal medicine residency programs. Even if somebody's going to subspecialize, I think they need to learn how to do outpatient medicine and to really understand the value of preventative care. Because as a subspecialist, there will be significant interplay between the subspecialist and the primary care physician. So I think you really need to understand the role of the primary care physician and appreciate that.
Thank you. And another question for Dr. Atluri. Were there medical societies or medical groups in India that were warning against the second wave of the COVID virus pandemic?
So that's a really good question. I really didn't see a lot of information out there on the health ministry or anything saying like, hey, this could happen. Maybe it's possible that I missed that, but I didn't see it because I think there was a lot of information that was kind of circulating saying that, India did really well during the first wave, better than anyone expected. And so again, there was that kind of misinformation that we were reaching herd immunity, vaccination was starting. So people weren't that worried about a second wave from what I could tell, or if it wasn't branded to the masses.
Thank you. And I think we have time for one last question for Dr. Self. Dr. Self, how much of subspecialization is driven by reimbursement models with fee-for-service rather than caring for populations and disease prevention?
So I think probably less of the initial drive towards subspecialization was driven by reimbursement models with fee-for-service, but of course, I think that's with the large amount of medical school debt that the average medical school graduate has these days. I think the reimbursement models and often higher payments in some of the subspecialties are a major factor in today's choice, or in today's subspecialty choices by residents. But I think, at least in an academic center, I think a lot of that too is intellectual. But I think there have been calls for addressing some of the fee-for-service models and looking at different payment models where subspecialists would be rewarded for, coordinating care with other specialties and working as a team rather than just everything operating as individual, separate entities to try to reduce some of the healthcare costs there.
Great. Thank you so much for answering those questions. Thank you so much to both of our speakers today. You both gave absolutely great talks. Thanks to everyone who presented during the Chief Resident Grand Rounds, and thanks to everyone who presented this year for Grand Rounds. This is the last Grand Rounds of the academic year, so we appreciate everyone for tuning in. We appreciate everyone who gave talks this year. I think now we are ready to show our QR codes. A big thank you also to Dr. Kadiwada, who organized all of the Grand Rounds for this year. This really couldn't have happened without her. Thanks everyone for a great year. And if anyone has any further questions, feel free to put them in the chat and I can go ahead and forward them along to our speakers and they can respond separately. Thank you all again, and we'll see you next academic year.